I will introduce myself again. I'm Lydia Green. I'm a paediatric neurologist working in Leeds. So I caveat that I'm not an adult neurologist, but we do work across the spectrum now. And I do research into neurogenetics of rare diseases. So I wear two hats at variable times across the day. And I help lead some of the National Service for the White Matter Service development. The reason I think Alexander's is really interesting is because it models, or how I'm going to talk about it today, it models really nicely what has changed over the last 4 decades in the world of rare disease and leukodystrophy. And some of actually what James said in his talk really feeds into this. So I'm not going to talk to you all about what is Alexander's disease, what happens here, what happens there. Now that will come into it. But I really want to just show you how things have changed just over the last 70 years and how that's really exciting, but also how we're all now relearning things that we thought we knew. And that's a really positive thing, but it also has its own challenges. So if we look at our timeline for I've got different things on this screen. There we go. So in 1949 was when Alexander's disease was first described by Dr. Alexander. He had a patient who had megalencephaly, so a bigger head. They had normal development up to 7 months of age, and then they had neuroregression. And unfortunately, that child passed away. And when they passed away, he looked at the brain tissue and found this buildup of Rosenthal fibers. So these fibers that shouldn't be there in clumps, and they were building up. And what he could do, even at that time in 1949, is he looked at the brain tissue and actually said, oh, Rosenthal fibers, they look like they're within the astrocytes of the brain. So our brains are built up of lots of different cells. But even at that first description, before he even labelled it Alexander disease, he saw a patient, recognised the symptoms, and looked at the pathology and tried to put all of those things together. Now, even when I started my practice, not as long ago as 1949, that's still how a lot of it worked. I saw a collection of symptoms, we clinically made a diagnosis, and sometimes I could get a biochemical test, a blood test, a scan, a gene test, but much less gene tests that confirm that. But a lot of my patients were clinically diagnosed. We didn't have a confirmative diagnosis. That's how we worked. Within 15 years, we had 5 more patients, and it was recognised that these patients are the same thing, and they then were labelled as Alexander disease. So what he saw in that normal early development, the regression, the megalencephaly, and then sometimes seizures within those patient groups, and a progressive course of neurodegeneration was seen in a collection of patients, and just 2 years after that, we then fully confirmed those suspicions that Rosenthal fibers were there, and they were probably in the astrocytes, and we saw them in the astrocytes. So even over the first sort of 16, 17 years, we're seeing that what we thought happened clinically did exist, and that's what we're treating. There's then a really long time before we get to the end of the start of this decade, and we talk about genetics. So in all of that time, we had labelled Alexander's, we had treated Alexander's, we had talked to families, patients, we talked about prognosis, and we just looked after our patients. It took all the way through to 2001 to then talk about the next steps. So this is a 50-year slide. Let's have a look at what the last 25 years have looked like. So now we're in the 21st century, and now we're going back to medical school and back to a laboratory workbench, because what I described as Alexander's then, so by the 2000s, I could tell you about clinical described Alexander's disease. I can tell you about infantile Alexander's, so presenting in the first 2 years of life, coming with seizures, regression, being life-limiting in 5 to 10 years. I could tell you about juvenile Alexander's, because they were the patients that presented a little bit later. They didn't always have that profound neuroregression, but often had feeding difficulties, swallowing difficulties, speaking difficulties, and often some motor instability, so they were a little bit wobbly. They didn't progress in the same way, but they still often had a progressive course over time, but that was Alexander's disease. We got GFAP, we tested those children. So these were paediatric patients with a clinical diagnosis of Alexander's disease, and the first test was 13 patients. 12 of those 13 patients have a spelling mistake in their GFAP gene. Excellent. The thing we've been doing for the last 52 years looks like we're doing okay. So we've got a gene. In the same year as this, we also had diagnostic findings described by Mayo van den App in Amsterdam, who's really been a lead in leukodystrophy and MRI recognition, and she delineated these are the features that if you've got a leukodystrophy, what characteristics of your leukodystrophy make us think of Alexander's as opposed to Krabbe, ALD, what is it? And we mapped those, and someone spoke about AI yesterday in one of the talks. And there is a real role for pattern recognition. So there are some diseases that really works for, but equally there's then a whole host of diseases where we don't have those specific findings. And my first clinical experience of Alexander's was a pair of twins who'd actually been not diagnosed with Alexander's on 3 occasions, despite the fact that they really, really looked like they had Alexander's. And it wasn't until we found an unusual way of the gene mutation, which had never been seen before, that proved it. But their MRI scan had ruled them out because they had lots of the right features, but also one different feature. So there are limitations to what we can do when we put our patients in a clinical and a radiological box. It's not always the same. We talked about yesterday the heterogeneity of disease, saying just because you've got this spelling mistake, you have that disorder and you look like this. This is a disease we've treated entirely like that for half a decade. You've had it because you look like this. But in the 21st century, it's not true. We now know more, but that makes us better in some ways, but it harder in other ways to label things in the same way. We're not always clearer. In 2005, we found spelling mistakes in GFAP in adult patients for the first time. So we've gone from pediatric patients we know have Alexander's to adult patients with neurological problems that we've then found have Alexander's. So we would never have labelled them as Alexander's at the start of that situation. And that expanded what we knew about Alexander's. So actually, we're no longer talking about you get an Alexander's diagnosis, it's neurodegeneration, it's life-limiting. We now have patients in adolescence, so we've moved on from here to adults to adolescents now as well, that have a much more attenuated phenotype. So we still see the vomiting, we still see the bulbar function, the instability, and some of the progression over time. But actually, you can have decades of normal development and life before that happens. So Alexander's disease labels is different. How I would have spoken to patients, I wasn't seeing patients in 2001, but had I been, the conversation about Alexander's is so much different to where we are now. And then I'm doing a big jump because I'm talking about what we understand. So even 2 years ago, I understood more about adolescent and adult Alexander's, and then the UK Biobank came along. So the Biobank is an amazing resource that collects blood, DNA, plus minus other samples and scans from a well population as well as an unwell population, and then does huge screening to look for patterns within that. And within the UK Biobank data, they found 36 different types of GFAP spelling mistakes, so variations in the GFAP gene, in 108 patients. 2 of those patients had a diagnosis of Alexander's disease. Those other patients, they did not. So we've looked at that patient and said, actually, a lot of these were asymptomatic, and I use asymptomatic in brackets because actually, when we went through the histories, we had quite a few adults that had vomited quite a lot, but that was it. But that's not a diagnosis. They weren't unwell. And we had a few where their speech might be a little bit different, or they'd had a bit of feeding, or they're a little bit wobbly, but none of them had a diagnosis, and they hadn't necessarily gone to their GP to say, this is a problem I need you to work with. So actually, from this data, we now know that A, Alexander's is more common than we knew. B, you actually can have a spelling mistake in your Alexander's gene and not have a diagnosis of Alexander's. You can be well, or as well as we know to label as well. But there are some things that does increase your risk of. So these families often had a family history of paternal particularly, but older age dementia in a parent. So is there something about, that wasn't Alexander's, that wasn't dementia, it was probably Alexander's, but we hadn't thought of it then because 20 years ago we didn't know about Alexander's in that setting. And then they had hypertension, so high blood pressure. So actually just having a GFAP spelling mistake means that you're at higher risk of having high blood pressure. Knowing that's important because high blood pressure, adult Alexander's might not kill you. High blood pressure that's not treated might do. So we need to know those things. And then there was also the combination of increased swallowing, feeding, unsteadiness, but that was a much smaller part. So now having a spelling mistake in your Alexander's gene doesn't always give you symptoms. It definitely doesn't give you the Alexander's symptoms I would have talked about 20 years ago. And not everybody in a family might get those symptoms. So it's not fully penetrant. You can have the gene without having the condition, and definitely without having full condition, as you would label it. But it might still mean that you need protecting from some of those other associated features that we can modify to make life better, longer, and of better quality. So I've talked a lot about how we diagnose and how I describe Alexander's disease, but what are we doing about that? So over that time, we have, from a research setting, we've looked at animal models. So animal models have been around a long time. Actually, we knew about GFAP, so the protein, and Rosenthal fibers back in the 1950s, GFAP protein 80s into 90s, and then people were doing mouse models to see if was GFAP, not the gene, but the protein, abnormal in children with Alexander, or with mice with Alexander's disease. When you come into this century, we're then now adding cell models to our animal models. So in 2006, there was a huge breakthrough in terms of basic research science where you can take a patient's cells, so skin cells or blood cells now, you can get stem cells from those. And if you have a patient's stem cells, you can make any cell in the body. So we can now make brain cells from that patient's cell. And it's a brain cell in a dish, it's an individual cell, but actually now I can make a Alexander's disease brain cell for this patient and their type of Alexander's, for this patient and their type of Alexander's, and then we can see why are they different? If we do lots of different stains and tests and biochemical markers, why is that Alexander's different to this Alexander's? So that tells us a huge amount of information about the disease, the pathology, and when we have rats and mice, does that spelling mistake in a rat or a mice look like if you had it in a person? Because what everybody wants to know is, can we make this better at the end of the day? Now, if I come up with a drug, I can't just give that to people. It doesn't work that way. I need to work out, can I give it to somebody else safely or something else safely and then build it into humans? But there's no point in me treating a mouse or a rat with Alexander's, with a GFAP mutation, if the mouse or rat with Alexander's doesn't look like the human with Alexander's, because it might fix the problem they have, but if the human never has that problem, it might mean nothing. And then the cost, we haven't actually talked about cost of trials, but the difficulty in rare disease trial, the cost of rare disease trial, all of that, if you can't prove it in a mouse or a rat, or you can't make it relevant to a human in a mouse or a rat, we won't even get that process started, never mind thinking about how successful that process might be at the end of it. So now we have animal models for a long time. We're looking at what the disease looks like. Rats actually for Alexander's are better than mice. They do have more of the same symptoms than, and I'm talking about typical classical Alexander's in that case. And cell models that tell us more about how it works in a petri dish, more about the molecular science, the movements. And then even more recently, we have those more advanced cell models. So now we're looking at organoids. So before I could take your skin cells, put it in a dish and get a stem cell, and then grow a brain cell. Now I can grow I say me, I'm generalizing very well. We can now grow mini brains in a petri dish. So now they're actually collections of lots of different brain cells. So we can look how those brain cells interact. And also, again, the recapitulation of the human disease. Do they also get those Rosenthal fibers? Do they get their clumps? Does it do what we know? And that's another way of looking at disease. Now, organoids don't do everything. So these are our organoids. So the top there, they're little mini brains in a little petri dish. So that's loads of little mini brain cells, they're about 6 millimeters. And then you put them in and you keep them in culture and rock them around a bit and grow them, and you can keep them for a long time. And then you can stain them, and you can do 3D modeling of them. So it's a little clump of a mini brain. So it's not a real brain, but it's a scientific lab-based version of it that gives us more information. So what do we know from a GFAP Alexander's organoid? They are bigger brains, so they grow bigger mini brains. So that is what we see in our patients. And they have different cell types than our control panel. So they have less neurons. Those neurons are immature, so the way that they make their brain cells is different. They have abnormal astrocytes, and they have reduced microglia. So our microglia are multifunctional cells within our CNS that help with maintenance, migrate loads of different bits, nutrition, support. So they're essential. So we can see they're different, and what they don't have in organoids is they don't have loads of Rosenthal fibers, and we don't understand that, whereas the mice and rat models do. So they're not the same. There is a real role for organoids, not just in understanding, but probably the biggest role going forward is going to be medical screening. We can make, I say easy, it's not easy, but it's quick and it's much cheaper. Makes organoids that are of this spelling mistake, of that spelling mistake, so not just Alexander's, but within Alexander's, the range of things, and then we can screen drugs on a big scale within that cohort to say, actually, what does it do? Does it work? Does it show like it might do anything? So that's a real basic indicator, which is important because rare disease is not funded. It's not easy. You don't often get a positive hit. So at this stage, we just need big, high-throughput models that don't cost much money and are quick, and then we can find, is there a drug out there that looks like this might work, that somebody then might be interested in taking forwards? And then we can take those selection. It doesn't tell if it's efficacious, if it's efficient, but it's that first indicator. Then you do your mouse models, your rat models, and put your drugs in there, spend a bit more money, develop those, and look at those, and then those ones that work are developed, and we move them through towards humans. So this is the very start of a very long process, but if we can't get the start right, we're never going to get to the finish. So human trials. There is only one treatment officially. If it's not licensed, it's a therapy, a trial treatment, so it's not registered and approved yet at the moment. So zilganersen, and I think, Rob, you're talking later this afternoon from Ionis about updates from there. So this is an investigational antisense oligonucleotide. So it goes, you inject it, it goes into your central nervous system, and it tries to reduce the overproduction of the GFAP protein, the thing that makes your Rosenthal fibers accumulate. Now, things I do know, so I don't know many things about it, but the Ionis trial is due to report, I think, next month or November for the first cohort of patients, which is the 2 to 65-year-old patients, and the outcomes from that. The under 2-year cohort, which has been recruiting, so the older cohort closed earlier. We had the under 2-year-old cohort. That's now closed to recruitment as well early in the year. So there's no currently actively recruiting Alexander's trials, but we are pending imminently results of the biggest thus far. So by the end of this year, we should have more information. Zilganersen's already been granted orphan-net status by the EMA. That was back in 2019, and fast-track designation at the end of last year by the FDA. And regardless of what's happening with the trial, so we can't put you into trial now, there are records being kept, because if things, similar to our registry, if things change and the landscape changes from trial to treatment, we want to know about that. Information is a really positive thing, because, and people have spoken in different settings across the weekend, because we want patients, we want information about our patients, because we want to get everybody in. But the more we know sometimes, so the breadth of the Alexander's patients we know about actually makes it harder to make a trial and a treatment that fits anybody in it. Pharma spends a lot of money to get treatments through, and we need to be able to prove those in trial. So we're going to have a drug, we want to know the drug works, and we want to know it makes this thing better. What if you have 400 patients and they all look slightly different? If you put all those 400 patients in a trial and everyone wants access to those things, it's actually really, really difficult at the end of that trial to say that thing was better, because you might not all have that thing, or your thing's slightly different to the other person's thing. So often for trials and research at the start, we need a really focused core group. So actually, it was interesting with Ionis because it was so big and it spanned the spectrum, but the core thing they were looking at might not fit for everybody, but there were lots of other end outcomes that will be looked at, because it's trying to get as much information from one group of patients in one trial without limiting the success of that trial by picking the wrong outcome measure that might mean that on paper, this one thing didn't work for our patients, but if you looked at everything else, there was improvement. So it's really, really tricky. So having more information is good, but it doesn't necessarily make all of the next steps easier. But what it does do, it really shows that our old-fashioned natural history study trials are more important than ever. It's all very well understanding more science, but we need to better understand our patients, because only by doing that can we make treatments and trials relevant, applicable to the actual patients we want to treat now, and accessible to the people that want to access them. So it's all very well doing a treatment trial for this bit, but if there's no patients now in that bit, and most of the patients are in this bit, it doesn't help. So there are currently some active natural history studies recruiting. So there's the Children's Hospital of Philadelphia have had a long-standing Alexander's disease trial, natural history study. And more recently, David Lynch and Charlie have launched the UK Alexander's disease natural history study for adults. So they're phenotyping the adult cohort. So all those patients that we don't understand from the biobank and beyond, they are the group that we are now much less able to talk to you about. The childhood Alexanders we've been talking about for 75 years, that's a bit easier. I mean, there's still patients that are difficult, but it's easier. But those other group, to get those treatments, those trials, those things up and running, we're at the start. We're at the start of that 75-year process all over again. We can do it better, but we are starting it. And these are invasive. There's things that are invasive within this. They won't be for everybody. Not everybody wants to be part of a natural history because, as James said, it's inconvenient, it's sometimes costly, it's burdensome in terms of investigations. So there's no pressure for everybody to take part in those things, but it is the first step of moving to things beyond just understanding what happens on its own, but how can we change the outcomes in the future. Fab. And that's all I was going to talk about. That actually lasted longer than I anticipated. I apologise. Thank you very much. Does anyone have any questions, or was I not clear about anything? Yeah. Yeah.
As well?
So the biobank's not leukodystrophy related. It's a massive, a lot of them are actually well adult, so it is a predominantly adult-based process. There are other bits of it. So, for example, there's a long read study that we recruit to in Birmingham and Leeds that we are taking patients with undiagnosed disorders, and children within that, and they sort of get added within sort of retrospectively. So it's a biobank study, but it's not this same big biobank. So we are logging into that, and that's a clinician taking information from a patient, and we're undiagnosed patients at the moment, putting them in there and doing different genetic workups. There is a really good website for the biobank, so if you just Google UK Biobank, but most of it is adult-based, unless you're in these are the little studies. And they're not little, it's hundreds of patients, but within certain centres. But where are you based? I think you're...
I'm from Northern Ireland.
Yeah,
so
they see you in... Are you seen in Manchester, or you see Hall?
No, London.
In London, yeah, I couldn't remember.
Yes, so...
We talked about it with the London clinicians because they haven't been recruited to the LRS, and now again it's negative patients at the moment. I think that will grow going forwards.
Thank you.
Anything else?
Lydia, based in your experience. Sorry. Yeah. Hey Lydia, it's Rob from Ionis. I got a question for you. Based on your experience, a lovely presentation. I especially appreciate how you broke down the timeline, and I think it really puts in perspective, somebody who's diagnosed this year, that we've really only known about this thing for probably a couple of people here, or about 70 maybe. Yeah. Alexander disease is a very new thing to us to understand. What do you see in your practice when you try to think about that endpoint question? What do you see, what would be something that you would have a conversation about with a patient regarding change in their disease progression, and understanding that you don't want to give medical advice. But I'm just curious, do you think there's something unique in Alexander disease from an endpoint perspective that you've thought about?
Do you mean in terms of assessment, or thinking about where they end up?
Yeah.
So I think, I'd love to say you're all very unique, but actually I think it's probably not unique to Alexander's. I think across the spectrum of a similar cohort of leukodystrophies, we see the motor change, the cognitive change, and I see that across the spectrum. I think we're really bad at tracking it. So once you have a diagnosis, we see you in clinic. I write my findings, and some 6 months I write down the same findings, and once I forgot to examine someone's eyes and they come to see me for an eye problem. So sometimes I don't write down my findings, and it's just really, it depends on the priority of the day. So I think in a clinical setting, we're not very good at tracking findings over time. And someone yesterday said, they went to for the CHOP trial for AGS, and they went, and in 2 days they saw everybody and had this whole thing, and they saw all the specialists. It was amazing. But that's in a research setting. You come to a research setting in my unit, we do exactly the same. The PMD trial we're about to set up, you get 2 days and you have every test in the world, and we do it all every 6 months. So there we're very good. So I think, no, there's lots of similarities between patients. I think there's not very many validated assessments within leukodystrophies, Alexander's or not. So some of the trials, there's an MLD score now, but we don't use those in practice. But a lot of the same scores could be used, but we should be doing them in clinical practice, not just in trial, and then comparing our cohorts, because not many of our patients will be in trial. I don't know if that answered your question. Sorry. Yeah.
I'm just going to make an example to our situation. Jan has only recently, like last March this year, been confirmed suffering from Alexander's disease. We had prior diagnosis going back to 2022 right, for functional hemiparesis after a fall, MRI scan done to rule out the fact that she hadn't had a stroke. So, but she had all the clinical signs of having a stroke, but not the medical evidence. Yeah. What we've seen since then is any medical incident sets her back significantly. Yeah. For functional hemiparesis, the treatment was the same as a stroke: exercise, walk, do this. In the July, she was walking 50 metres behind a walker, got COVID, never walked again. Yeah. Had another fall, couldn't stand. Yeah. Last December, had another fall, could not transfer. Yeah. Then in April this year, pneumonia, and this is how she is now. So it's every time something medically happens outside of Alexander's disease, yeah, and it was after her pneumonia, yeah, that then it was, we don't think the diagnosis is correct, yeah, and in rehab, yeah, the lady who saw Jan in rehab said, I don't think it's functional hemiparesis. Yeah. We did a history. I was allowed to do a history, which I did back from 2015, in terms of all of the stumblings, all of the things that had happened. That went to the MRI, and that lady requested a specific person at Frimley Park to review the MRI scan. And they came back with Alexander's disease. And nobody in Farnham Hospital knew anything about Alexander's disease. Yeah? It was the psychologist's boss who said, have a look at Alex TLC. And that's where we started to find out. So the progression, in our circumstances, downward progression, yeah, is always linked to another incident. So it's protecting the patient, yeah, from the other outside factors, not Alexander's disease, because we know Alexander's disease won't kill her, yeah, but we know what will kill her, yeah. Okay?
I think we're so privileged because we get to share in all of that, both in clinic and in weekends like today, because I think it's unique, but actually there's echoes of that between everybody's journey of some degree. And we're saying, oh yeah, it's great because we know more now, but actually has that filtered down to other people knowing more? I mean, they didn't know this common stuff, so I'm fairly confident they don't know the rare stuff. So it is better, but it's also not easier. That's different. There's two things that I didn't say that were on my notes that I clearly forgot about. So firstly, for the biobank people, they did MRI scans for 6 patients. 2 of them already had a diagnosis of Alexander's disease, so they had some white matter change. The other 4 patients had no white matter change, so you wouldn't have called it. But all of them had brainstem changes, so they all had slimming of a brainstem, and your brainstem is your messaging hub, so getting your information from here down to here. So all of that wobbliness and steadiness, sometimes you can scan a patient and still not know, and it's wild, because you label it as one thing, and if the scan doesn't look like, how do you get there? So that was my first, yeah, exactly. Yeah. Yeah. And you need the right people to look. So I spend my entire life, because people call everything a leukodystrophy and it's not, so there's that way. But there's also the people where you ignore that because it was just an old age change. Because I think I don't see that in my practice, but I know that my adult colleagues do. And there are changes, and mine are overcalled in pediatrics and yours are undercalled in adults because it's just something else. So, yeah. So it's something else. The head injury thing is interesting. So there's been lots of report of minor head injury causing downturns in Alexander's. And they actually did a study, I think, last year, the year before, in mice, and gave them head trauma, but not head trauma enough to cause damage on its own. And although the reports are wide, so lots of people say it, they couldn't demonstrate it. But it just shows that the mouse and the rat don't represent everything that we know, because they didn't have an outcome that they saw a deterioration in the test. But lots of people say that mild stuff. But again, unless we tell you that, you shouldn't have to work it out on your own, unless we tell you that actually protecting and keeping you well helps the other stuff.